Hi everyone, Dr. Pannucci here. I was asked to give this talk at the February 2022 Northwest Society of Plastic Surgeons meeting, and it's an important talk for plastic surgeons for sure, but it's also an important talk for patients considering elective surgery. The talk was part of a larger panel on COVID in plastic surgery, but specific for me, I was asked to discuss how to safely balance elective surgery and patient safety. So let's get right into it. Now, I think that it's important to note that these are the best data available in February of 2022, but COVID continues to emerge and we get new data. And so this is a talk specific about what is known this month, February 2022, and specifically targeting the elective surgery, plastic surgery population. Now, this is not a new topic for me. At the Virginia Society meeting in late 2020, I was asked to give a talk on venous thrombosis, blood clots that occur in plastic surgery patients, with a particular highlight in patients recently diagnosed with COVID. And as you'll see, this dovetails very nicely into the topic for today. Now, there are working paradigms published out there, this one from Janus et al., but when you really delve into them, they're less about how to safely perform surgery at the independent or the individual patient level. They're more about how to appropriately use resources to ethically and appropriately distribute surgical care. There are some data looking at plastic surgery and specifically safety of outpatient plastic surgery during COVID. This is one study published in early 2021 based on survey data from that first year of COVID that looked specifically at 112 surgeons in the Los Angeles region, saying, what are you doing for COVID right now and what has your experience been? So at least based on data that came out from the summer of 2020, the majority of surgeons were getting pre-op COVID tests. And it was interesting that about one patient in 150 who was asymptomatic was coming up as positive for COVID. And in addition, about one patient in 1,000 who had surgery was coming up as positive within the next 2 weeks. Now, these data are helpful for us to understand baseline rates, but don't necessarily definitively answer the question of how do we do safe surgery in COVID? So why is this relevant? Well, we know based on data from other populations that COVID positive patients can be at higher risk than most. And specifically, they're at higher risk for postoperative pulmonary or lung complications, as well as postoperative coagulation, specifically increased risk for blood clots. So why does that happen? Well, I guess I wasn't surprised to hear this. You know, in 2003, I was working in the ICUs at Washington University in St. Louis as a medical student. During the H1N1 crisis of 2009, I was in the ICUs at the University of Michigan, and for MERS in 2012, I took care of those patients at the University of Michigan as well. And for all of these patient populations, we saw that this viral lung-based phenomenon became a systemic problem with head-to-toe complications. Now, I'd be remiss not to point out some of my collaborators in thrombosis at the University of Michigan who have looked at this complication spectrum, especially around venous thrombosis and blood clots, pretty extensively in the hospitalized and surgical population. And they've shown that patients in the ICU, patients admitted with systemic viral illness, can be at higher risk for blood clots. Now, why is that? Well, I stole this diagram from this article about why is risk for blood clots increased in patients with viral illness. And it is because there is crosstalk between the inflammatory cascade, which gets ramped up as you have a severe viral illness. As you increase your level of inflammatory cytokines, eventually you reach the point at which you increase levels of something called tissue factor. Now, tissue factor is interesting in that it not only increases your systemic inflammation, but it also has crosstalk with the blood clotting pathway. And so at some point, when your body head to toe has an increased complement of inflammatory mediators, you will also become more likely to clot. And this is the process how COVID-19 causes that activation not only of the systemic inflammatory system, but also upregulates blood clotting. Now, it's interesting when you look at patient safety, and specifically at clinicaltrials.gov, and if I put in the keywords COVID-19 and elective surgery, there are 56 studies currently ongoing, registered on clinicaltrials.gov, that seek to examine how do we do safe surgery in patients with COVID. Now, these studies have various things that they're looking at. Some of them look to better understand the incidence or the rate. Some of them look at what happens when you do surgery in COVID-positive patients. Some of them look at the role of surgery delay, which we're all being forced to ration care somewhat due to hospital availability, and looking at the impact of critical surgery delay for patients with cancer, but also for elective surgery like hip surgery and knee surgery. So it's interesting, you may be wondering, this is supposed to be a talk about COVID and elective surgery. Why are you discussing blood clots like deep vein thrombosis? Well, as I've shown you already, there are crosstalk between the two. And so blood clotting phenomenon can be a useful marker for severity of COVID illness and also for when patients' physiology is returning to normal. So I think as an interim summary slide, it's pretty clear that the systemic inflammatory response persists even after COVID improves. Anecdotally, right? Ask anyone who's had COVID. They don't feel great right away. They might have achiness, muscle weakness, trouble getting back to their day-to-day activities, but also as evidenced by ongoing blood clots that happen even after your COVID symptoms resolve. And we'll look at some of those data in a second. So really the question here is, when does the patient's physiology return to normal, which is super important when you're considering when can you safely schedule elective surgery. This, of course, then brings the elephant into the room, the big question: when can you safely do elective surgery in patients diagnosed with COVID? I think it's important to talk, first of all, that elective surgery, surgery that you can schedule, is very different than surgery for things like cancer or broken bones or things that are time sensitive. But focusing in on the elective population, I'm going to draw a lot of the data from this NIHR Global Health Research Unit, who has this global surge, COVID surge database. And as of last week, when I downloaded this image, they're pulling data from almost 1,700 centers spread out across 122 countries, and they're pulling data for more than 140,000 patients. When you're talking about rare events research, this is a pretty good database to be pulling from because it has enough numbers to be statistically powered to answer the questions that we're interested in. So first of all, let's talk about pulmonary complications. This database was able to look at over 1,100 COVID-positive patients who had an operation. And I think it's pretty clear that operating in COVID is less than ideal because amongst those patients, more than 50% had some sort of pulmonary complication after surgery. And amongst the 50% that had a complication, they were more likely to die, as evidenced by increased mortality. Data from that same database was able to look at COVID-positive patients. They looked at almost 130,000 patients, most of whom did not have COVID, but some of whom did. And when they compared them, they found that patients who were COVID-positive were more than 4 times, about 4.5 times, more likely to have a postoperative venous thromboembolism event, blood clots in the legs or lungs, compared to those without COVID. And for patients who had a VTE or a blood clotting event, those patients had a higher mortality than those who did not. So clearly this is giving us evidence that operating on COVID-positive patients is less than ideal. Well, how long does that less than ideal circumstance last? Well, this is another study that followed admitted medical patients with COVID. They didn't all have surgery, and showed that after discharge, about 1 patient in 200 developed a postoperative blood clotting phenomenon. And this was sort of on the same line as the rate of post-discharge blood clots that occur in the generalized hospitalized population. But this is showing that even when you leave the hospital, it doesn't necessarily mean that you're physiologically normal, as evidenced by that higher risk for blood clots. And another paper which suggested that the risk of VTE, and by extension your physiology not being completely normal, is unlikely to disappear, specifically at the hospital discharge time. So as another interim summary, we know, based on data from that global surge database, that operating on COVID-positive patients results in a higher risk of pulmonary or lung complications and also a higher risk of VTE or blood clotting complications. We also know that just because you're discharged from an inpatient admission or just because you never need to be admitted does not necessarily mean that you are completely physiologically normal. Which brings us around to the real question of when do patients get back to being normal physiologically, and by extension, when can they safely have elective surgery after COVID? So these were data published in November 2020. This was a case control study, meaning that the COVID surge group found 122 patients with COVID and matched them 4-to-1 with similar patients without COVID. They showed that when you looked at lung complications and mortality, that patients had the lowest risk of both at least 4 weeks after a COVID positive test. And these were all patients who had surgery. So that provides some evidence that says for surgery, risk of surgery goes back toward normal by 4 weeks. Looking at a larger section of data, when that database really got up and running, they later looked at the 30-day mortality, again as a marker of abnormal physiology, for over 140,000 patients, some of whom had COVID, some of whom did not, all of whom had surgery. What they showed was that at greater than or equal to 7 weeks, risk of mortality returned to baseline. That means that you could argue that physiology has returned to normal at greater than or equal to 7 weeks. So somewhat conflicting data, 4 weeks, 7 weeks, but taking all of these data into account, they really help to explain the existing February 2022 recommendations from both the American Society of Anesthesiologists and the Anesthesia Patient Safety Foundation. They are recommending that the timing of elective surgery after a COVID positive diagnosis be delayed 4 weeks. 4 weeks from the time of that you were diagnosed for patients who are asymptomatic or with mild symptoms. 6 weeks for patients who are symptomatic and who were not hospitalized. 8 to 10 weeks for patients who were symptomatic and who have other medical comorbid conditions or who were hospitalized, and even out to 12 weeks for patients who were admitted to the ICU. And again, just to say it again, these are recommendations for elective surgery after a COVID positive diagnosis. You know, this is a constantly evolving topic, one in which we are forced to constantly aggregate new data and make decisions based on the best available information. But at least in February of 2022, these are the current recommendations and the data behind them being recommended by major anesthesia and patient safety organizations. And so I'm certainly tending to follow these as part of my own practice. I really appreciate the opportunity to give this talk. Hopefully all of you out there in the social media world have learned something, and perhaps this serves to help you better understand when surgery, elective surgery, can be safe after a COVID positive diagnosis. Dr. Pannucci here, signing off until next time. Thanks very much.